Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan, Lalani, and Christopher Wallis.
Hello and welcome to The View on GU. I'm Aly-Khan Lalani, joined by my co-host Christopher Wallis. We are post-GU ASCO, recording this early in February. Chris, it's a leap year in 2024. What does that mean to you? How do you celebrate it?
Great to talk again, Aly-Khan. I'm glad you made it back from San Fran as well. So leap year, I have to say, I'm not really a big leap year celebrator, but this year we're lucky we're going to be in Mexico. So my kids are going to enjoy one more day of sun and sand. So how about you?
Awesome. No, I mean, it's great. I always wonder about this leap year. I remember as a kid, I think The Pirates of Penzance. I can't remember if it was a school play or if it was a book, but I know the main character was intended to be an apprentice until his 21st birthday, but because he's born on February 29th, that would be like when he's 88. So that was part of the story. So I don't know if any of our viewers or listeners are born on a leap year or their kids are. Maybe they can share. When do they celebrate this? I always wonder about these small things. But yeah, leap year. Big. We're in February and we are post GU ASCO. This is really meant to be a takeaway, practical, takeaway from GU ASCO. We've already covered the data in our other podcasts. So, Chris, let's cover the big buckets again: prostate, bladder, kidney, and then any other miscellaneous that we really enjoyed. Let's start with prostate cancer in the MCRPC setting. For patients who have not been treated with systemic therapy but are on ADT, we saw the Breakaway trial. We reviewed the data already. What's your big take home about this first-line, previously untreated MCRPC space, especially for patients when it comes to genetic testing and some treatments around that?
Absolutely. And so I think, the Breakaway data help us build on what we already knew from, PROPEL and Magnitude and TALAPRO-2. And really, I think, is important for the urologist because, these, when you put it all together, really highlights the importance of biomarker-driven treatment in this disease space. And so again, BRCA was really a selected patient population with those BRCA1, BRCA2, ATM mutations. And when you hit MCRPC, it can sometimes be hard to find whether patients have those mutations or not, right? Prostate's a very bone predominant metastatic pattern, and getting genetic testing or tumor testing out of a bone met can be really difficult, both painful for the patient and low yield in terms of the genetic sample. And so when you have these high risk patients, we want to get that information when it's more accessible to us. And really those prostate biopsies and prostatectomies, when they're happening, are a great opportunity to get somatic tumor testing done. In lots of places in Ontario, this is reflexive for those high risk patients, or if you're indicating on your requisition that there's a relevant family history or there's metastatic disease at the time of diagnosis, you can get reflexive testing. But that's not always a given, and it requires a little bit of interface between the urologist and the pathology teams, I think. And when we put the data that's come out in the last year or two into context, it really emphasizes the importance of knowing what's going on for our patients, both the somatic tumor testing, also the germline genetic testing, which obviously can be done at any time. But there's a significant proportion of patients who are going to not have germline mutations and yet have relevant and actionable somatic mutations. And so really, emphasizing that importance of getting the somatic mutation status when we can, really to keep open all the best options later on down the line, because putting these data from BRCA in context with PROPEL and Magnitude and TALAPRO-2, it really highlights that this is a treatment option that's probably best reserved for that, maybe arguably BRCA2 predominant, but certainly the other HRR patients, and that gives us an opportunity to give our patients a leg up and keep good doors open down the road. And alternatively, if we miss the opportunity, it can be hard to catch back up, because I don't know what's like for you guys, but for us, trying to get ctDNA or a liquid biopsy is not so easy. And so when we have the tissue, it's good to use it.
No, I mean, I agree. I think the theme really And again, for our viewers and listeners, this is more about takeaway themes about testing these patients as early as possible. There are treatment implications, probably the pair of PARP and ARAT together, if applicable, matters. And as you say, still some uncertainty about all the alterations that matter. The labeled indication will allow things like ATM. How valuable is that in terms of the benefit for patients and other options they could use instead? But no, I agree. I think the future would be to have ctDNA. I know some jurisdictions have that, but again, it's not in the water or ubiquitous as a standard of care across all provinces. So it might be nice for some institutions to have that, but the reality is we're talking about the whole country here and coast to coast to coast. I think the future should be having ctDNA or at least an iterative on treatment assessment of these alterations, at least at a certain time point, would be helpful. So no, I think it's a great theme test. We have options, and I think we're showing probably the pair together, notwithstanding small numbers in that trial, is probably the way to go in light of the other phase 3. So I totally agree. I think that's a good theme to take away.
Absolutely. And, as we think the next steps in mCRPC treatment, I think for many people, the ARSIs or novel hormonal therapy is going to be your backbone of treatment, your first line option in really any advanced prostate cancer space these days. And we saw some data from CONTACT-2 in mCRPC as a sort of follow-up next line of therapy. I'm sort of curious both how you see the IO and TKI combination, but also what we make of when is that novel hormonal switch that they used as a comparison arm, when is that appropriate in our clinical practice?
Yeah, I mean, both components. The first one, we did talk about this in our podcast immediately after GU ASCO, and I think really the takeaway is that I think the field is still considering knowing the component that Cabo has played in this disease setting. So cabozantinib monotherapy against prednisone, and then realizing and seeing the data available for PD-1 or PD-L1 type treatment immunotherapy as less than impressive. To what extent will the combination change standard of care? I think, again, some jurisdictions may seek this to be approved, but largely I think most places around the world, at least as of this recording, aren't necessarily seeing that as pushing the needle. But I do agree with you. The conversation that I think has come from this is this whole NHA to NHA switch. And this part I think is not so much for today around should that be part of all trial design, because I agree that will evolve. There were some trials where it was reasonable and maybe more historic, and perhaps we should be moving the control arm. I get all that. But I think the real conversation is practically, day to day, when should we be doing this? And I like that has opened that conversation up. And, to me, in my estimation, I think it's, if you zoom out, largely going to be the minority of patients. I think we all have folks that, for a variety of reasons, have, let's say, clinically slow progressing mCRPC, low rising in biochemical PSA level, not much or significant change radiographically, and clinically doing fairly well, but you may want to intervene. And perhaps there's other reasons why it's not necessary to get chemotherapy or another agent right away. Perhaps a few years ago during COVID, it might have been more appropriate to seek a switch. And I think it does come down to, what are you switching? Are you going from a drug like abiraterone to enzalutamide, which appears to be better than the reverse? So this is a nice conversation to have. I think those are the kind of patients I would use it in. And I think it's going to be, if we're really honest, the minority of patients anyway. So I think if we keep it that way, then I think we can take that learning from CONTACT-2 as to what do we really do about NHA to NHA switch. But, again, love to hear what our viewers and listeners think about that. I think that, to me, makes the most common sense patient kind of phenotype to think about this in. But I think that's a really great way to package prostate up. Let's kind of pivot with our remaining time to the urinary cancers. It was awesome to see data that reinforces the multi-D care in a perioperative management for RCC and bladder cancer, not just because this is kind of the ethos of our podcast, but let's, where do you want to take this? Why don't we start with RCC, big OS data, again, just maybe your theme and practical takeaway for how we action this.
Totally. And so, we discussed this in a lot of detail immediately after the meeting, but to see an overall survival gain with adjuvant pembro in the Keynote trial, I think it was really gratifying for a lot of us who treat RCC patients, and pretty remarkable given the long road of adjuvant therapy in kidney cancer. And I think when we get to an OS benefit, it's a little bit atypical in the adjuvant space, right? There's a lot of adjuvant treatment done in our community across disease sites that doesn't give an OS benefit. And so really seeing that OS benefit, I think, re-emphasizes the value that this treatment paradigm offers to our patients. And so now, in that context, we really have to think as a community about how we roll this out and how we make it happen. And I think, I was talking with a couple of our colleagues and friends in the last few days. To pull off adjuvant really emphasizes the importance of multi-D care. You need essentially the sender, the referring physician, and the treater, the receiving physician who's going to give the prescription, right? So in this RCC context, we need the urologist to understand the data and understand the importance and initiate that referral on the patients they've just operated on. And we need the receptive medical oncologist to take these patients, understand the benefit of pembro, and help get our patients this therapy. And so we really need that multi-D care. We need that good collaboration and communication, because in part in the adjuvant space, we have a little bit of a time crunch, right? We need to get these things done in a relatively timely way. We have patients recovering from surgery that we need to balance their surgical recovery. We need to get them through the appropriate workups, make sure that we're restaging them and confirming that they have non-metastatic disease, and then get them into their therapy. And I think that emphasizes that sort of collaborative approach to care. And it's going to differ from center to center. Everyone's going to have their own pathways, but really understanding and, at a maybe local level, working on what you're going to do and how you're going to do it so that these patients can really benefit from the, OS advantages that we've seen.
Yeah, no, and I'd love to pick up on that, because I agree with you on the data. I think there's going to be lots of people following up saying, let's see how many folks actually recurred, got treatment. For the patients who unfortunately have died on that study, how many people actually recurred and got immunotherapy from the control arm. I think there's more to come. But let me pull on that thread a bit about institutional practice. I'm curious to hear what you think you'd prefer, either your institution or urologists as a whole. But, at our site, once we had DFS, advantage, and we had the Keynote 564 trial, I think we had a conversation with our urologists. I think all tumor groups should be. And we just felt that as long as somebody had met criteria for the trial, that we would want and encourage that referral. I think the conversation then needs to be had. It takes time in a medical oncology clinic. Yes, that creates some pressures. Obviously, we want to see them in a timely way. Time from consultation or referral to consultation can be adjusted in an adjuvant setting, so long as you get them with a tight window. But our approach has been, with our urologists, just refer, book that first surveillance CT, and we'll have a very clear communication back with the urologist as to what the patient has decided. Do you think that's something you would like to see as a urologist? Just the receiving team, as you say, is open to just seeing all these people. Would you, or do you think institutions are going to pick and choose and say, okay, out of the Keynote 564 group, these patients, please refer; these other ones, hold on to? What do you think is the most equitable, but frankly, most time efficient way to think about this space?
Yeah, I mean, I guess to some degree that comes down to what do we think of the subgroup data from the trial, right? And we don't have that in a great way with absolute differences. We saw the forest plot, and when you look at the relative effects, I just don't know that we have enough data from this trial to say that someone who met inclusion criteria definitely didn't derive a benefit from adjuvant therapy. So even that intermediate high subset, the T2 grade 4s or T2 sarcomatoids, I think there's enough A, biologic rationale, and B, data out there that for me as a urologist, I wouldn't want to gatekeep and hold those patients back from at least having a conversation about potentially getting this therapy that's going to benefit them. So from my perspective, the way I practice, I want to send everyone who meets inclusion criteria. And part of the timelines there is I need to see the patients at least back for a path review, because not infrequently, these bigger, nastier tumors, I'm not biopsying them pre-op. And so, we really do need to reemphasize that this is a clear cell centric trial, right? And so a few times in the last month or two, I've got a, T3 that I had a pre-op conversation with adjuvant therapy, and yet they come back with, chromophobe histology or papillary histology. And so suddenly I'm backpedaling. And so you can't have it, too integrated into the flow, I guess. You still need that, urologist to minimum review the path, make sure that they are truly eligible, and then initiate the referral. And to some degree, that has center level variation in what the timeframes are for that, pathology to come back. But at the worst case scenario, we should be talking, maybe 4 to 6 weeks, and so that gives us still plenty of runway to make this happen. And so, from my perspective, unless the med-oncs tell me they don't want to see them, if you're meeting inclusion criteria for the trial, I think it's at minimum worth a conversation.
Mm-hmm. No, I agree. And I think that kind of dovetails nicely into the other urinary cancer with adjuvant data, and that's the urothelial cancer setting. And I think we can probably safely say more of the bladder cancer setting. I mean, I think, again, we've unpacked this on our previous podcast, but I think the real takeaway is that a lot of these patients are often seen in multi-D clinics, or where radiation oncologist, surgeon, and medical oncologist see the patient together, or in some sort of multi-D collaborative approach prior to surgery, because there's a neoadjuvant chemotherapy conversation. And so, certainly our institution does that. We can hand the baton off pre or post-op. Some of these patients could get radiation, but that's not what this trial was looking at. I think really my takeaway from Ambassador and the pending data from Checkmate 274 is, certainly patients who are post-neoadjuvant chemotherapy, so by definition cisplatin eligible and still high risk, I think adjuvant immunotherapy makes very good common sense there. There had been some speculation that PD-L1 status might matter, outside of English-speaking Canada and outside of the US. There are some jurisdictions that only approved adjuvant immunotherapy on PD-L1 status. But I think there's some challenges with that biomarker across trials, and an Ambassador would tell us maybe that's not the most critical biomarker. So I would not pin my treatment, if I could, on whether it's PD-L1 high or low per se. Again, we need some overall survival from Checkmate 274. But, I think the other question that we have started to see some signal on is upper tract disease. It's not clear that adjuvant immunotherapy has significantly benefited these patients, probably a bit about disease biology for upper tract and the power of these patients in terms of how many patients were in these trials. But I do think bladder cancer, again, multi-D, needs that baton passing between neoadjuvant treatment, definitive surgery where applicable, and then adjuvant therapy thereafter. So another beautiful context from multi-D setting.
You said a couple of times there, we need to see the OS data. And so I'm wondering, how you see that. Do we need OS data to be doing this, or does a DFS benefit give our patients enough that, this is actionable across our disease spaces?
Yeah, I actually think the OS data, for me, we've been acting on DFS. I think for the jurisdictions where they've largely approved based on PD-L1, I think it would be nice to not require PD-L1 status. And this is where perhaps OS, if it's seen irrespective, or the interaction between PD-L1 high and low does not differentiate the OS benefit on PD-L1. I think that would be nice to take handcuffs off of some jurisdictions that have elected that way. But no, in our clinic, we've operated similarly like RCC. Once we had DFS, this was an available, approved option. We have been discussing with our patients. And I think, again, this is where the baton passing between specialties is critical, and multi-D clinics are helpful for that. But at least if there's good communication, I think that can be actioned.
Immunotherapy is clearly becoming a backbone in a lot of our GU cancers. And I'm interested in your thoughts in the med-onc clinic as we think about how burdensome this can be. What your takeaways were from the data we saw about sub-Q versus IV therapy.
Yeah, I mean, I enjoyed this a lot. I think many of us did. Not so much from efficacy per se. This was a small trial looking at IV versus subcut, largely pharmacokinetics. But I think the real theme and takeaway, and we've discussed this data in our podcast after GU ASCO, but I think it is going to start to raise the bar now about when we leverage new drugs like immunotherapy, how is it given? And so the advantages of subcutaneous treatment, I think, will have impacts for patients if they're on treatment and don't need to physically come to a cancer center, obviously still being appropriately supervised. I think for cancer programs themselves, ensuring that as these vials are drawn up and ready for delivery to patients, how can you batch neighborhoods? How can you deliver this in a way that is efficient from a pharmacy perspective? Do we leverage some other clinic delivery models of care that can help all of us in our system? So I think there's a bit of a system and a hospital infrastructure issue that can be potentially assisted in some way by going subcutaneous. And so I think there's lots of opportunities there. I think Canada would be well placed, just given our geographic kind of layout with how far people can live from cancer programs, and then having really good learnings. Again, we learn from other disease sites, and within GU, look no further than prostate cancer, where we've had a lot of success with kind of ADT delivery. Obviously, this is a different mechanism of action with immunotherapy. So that's really the big takeaway I got. I mean, I think the available data has provided us enough to say at least this appears to be safe, tolerable, and active in patients. I think with the non-inferiority designs that we currently have, to say it's more efficacious, I think would be a stretch. But I think actually, to me, the learnings and the takeaways are really around, hey, this is a really exciting way to deliver a drug to patient that may be more feasible for all the stakeholders involved, most importantly, the patients and their families who often need to come to cancer programs. I think one of the questions that came up was, do we need to design and embed future trials to do phase 3s to show efficacy? I'm not sure we need that per se. I realize these aren't biosimilars, but we have had other data that so long as it's safe, we have kind of substituted deliveries of how drugs are given. But yeah, I actually think the next phase of clinical trials that embed immunotherapy, could there be ways of embedding the more feasible, perhaps non-intravenous option insofar as it's safe to do so? So, to me, a lot of upstream implications from that.
Absolutely. So, there's been always a big wave of data that comes at us every one of these meetings. And I think, it's nice to review the data as we did initially, but now, with a little bit of time to digest it, try and think about how we're putting it into practice. So if this has been of interest or of use to you, we would really love it if you liked or reviewed, subscribed, give us your feedback so that we can make sure we're giving you what you need. And I want to close by just saying thanks again for joining us. And on behalf of my co-host, Aly-Khan Lalani, I'm Chris Wallis, and we hope you join us on the next episode of The View on GU.